Hey there, it's Dr. Justin Marcagiani. Today we are doing a live podcast. We're going to be talking about thyroid labs and TSH. Why is it important? Why is it maybe a little bit overrated? We're going to go into this. And again, make sure you hit the thumbs up, give me a subscribe, and hit the bell as well so you get notifications. I'm one of the only health professionals that sees patients and does a lot of these live interactive podcasts slash Q&A hybrids. I really want to get lots of interactive involvement, and I want to get your feedback. I want to get your thoughts, and I want to interact in the podcast live information so we can make it even better. All right, so let's dig in. So when we're assessing thyroid function, one of the big obvious things that we're going to do is blood testing to look at your thyroid. Now, even before that, you may have thyroid symptoms. You may have cold hands or cold feet. You may have hair loss, outer third of the eyebrow issue. You may have mood issues like brain fog, mood issues, depression, constipation. Those are more of the subclinical, meaning let's say atypical, like they aren't what comes to mind if you go see your medical doctor when it comes to thyroid. The typical ones are going to be cold hands, cold feet, hair loss for sure, the depression, the anxiety, the mood issues, the constipation, low or slow bowel motility are typically going to be less talked about. Just FYI. So we're going to maybe do a palpation. They're going to look for thyroid swelling. They're going to look for thyroid inflammation. Why would that thyroid be swollen? It could be because TSH is elevated. TSH is the whipping thyroid hormone. It's the person that sits on the horse carriage that whips the horse to make the horse go faster. Think of the conductor whipping that. The harder and the more he whips that, that's like TSH going up, trying to get that thyroid to make some thyroid hormone, typically T4. Tetraiodothyronine. T4, tetra means 4, okay? And then iodothyronine. So that's 4 molecules of iodine bound to typically a tyrosine molecule that makes your T4, your active thyroid hormone. That gets converted and activated down the road with the 5-deiodinase enzyme that's selenium-based. So we need selenium, and we need other nutrients like vitamin A, copper, zinc, magnesium, vitamin C, typically some glutathione, maybe some superoxide dismutase, a lot of good compounds there that are really designed to help with that conversion. Also, cortisol imbalances, too high or too low. Same with insulin, too high or too low, can also thwart that thyroid conversion. So your conventional doc's going to, number one, kind of do an audit of your symptoms. Number two, they're going to do some palpation to look at the swelling. Could be high TSH, could be an elevation in thyroid antibodies, TPO, thyroid peroxidase, or thyroglobulin antibody, and that could be whipping the thyroid, not quite the same as the TSH, but more like someone putting daggers or stabbing your thyroid. Your antibodies actually attacking. So TSH is different because that's your pituitary talking to your thyroid, but raising the volume, and that can cause swelling if the TSH goes too high. Then we have the thyroid antibodies, which are your immune system coming in for the attack. And that's really trying to attack the thyroid. That's a little bit different because that can actually cause a lot of long-term damage as well. And a lot of that functional thyroid tissue that makes thyroid hormone could really be impacted and produce less hormone overall. And you may need to actually be on thyroid hormone for a longer period of time, if not your whole life, depending on how long an autoimmune attack's been going on for. Most people that I see, there's been an autoimmune attack to some degree for at least a decade, typically, before I see them. So it tends to be happening at a very subclinical level for many years before people even notice any symptoms. That's kind of the scary thing about it. It can be going on for such a long period of time. All right, so we talked about kind of the physical assessment, right? They may have you swallow some water. They may palpate just above and below the Adam's apple while you swallow. So here's your Adam's apple. They're going just maybe a centimeter or so outside, and they're feeling if there's any nodules, right? Typically, you'll just feel like a little bump. If it's a nodule, they'll feel if it's swollen, where it's a little puffy. It's sticking out more than normal. Of course, you need a baseline to know what normal feels like, but when it feels a little bit more puffy and kind of sticks out a little bit, once you feel a couple of normal ones, you can get a sense of what that feels like and looks like. Now, it's probably autoimmune, TPO, thyroglobulin. It could also be potentially Graves', but that's usually a minority percent of the cases, usually 1 or so percent. 90-95% plus are going to be Hashimoto's in origin. Now, Hashimoto's is an autoimmune attack that involves TPO and thyroglobulin, and it tends to fatigue the thyroid out over time, but you can hyper off the bat. And then the Graves tends to affect the receptor sites or the stimulating immunoglobulin that causes the thyroid to make more thyroid hormone. Hashimoto's can feel like Graves in the beginning, so it's really tough to know the difference. Typically, you're going to be looking at TSI and thyroid receptor site antibodies to differentiate the two. Again, hyperthyroid symptoms with Hashimoto's isn't that big of a deal. With Graves, it can be a bigger deal because it can cause potential stroke, because you can really ratchet up those thyroid numbers very, very high, much higher than you could with, let's just say, a Hashimoto's type of an attack. But it's always good to get both of that assessed. Now, most people that are going to see their doctor, they're kind of in this no man's land where the first thing that's really being looked at to assess what's going on is TSH. Now, I mentioned earlier, TSH is like the whipping hormone, right? That's the person in the carriage whipping the horse, right? So they're looking for that whipping to start going up a little bit above. Now, according to the American Clinical Association Endocrinologists, ACE for short, they say anything above 2.5 may be a problem. So we start looking at things a little bit more closely once the TSH goes above 2.5, me about 3. Once it's going above 3, I'm a little bit perked up and I'm paying very close attention. Now, conventional endocrinologists typically won't care until it goes above 4.5 to 5.5. I always tell patients the easiest way to cure your hypothyroidism, if you're diagnosed conventionally, is if you have a high TSH on the West Coast. Remember, the TSH on the West Coast is a 4.5. You go to the East Coast, it's 5.5. You have a 4.75 on the West Coast, take a trip from LA to Boston, and now you're cured overnight. I wish it was that simple, though, but seriously, you'll see in the lab reference ranges that changes that easily. So 4.5 to 5.5, I think it's a little bit late when it comes to assessing thyroid hormone. Some don't even care until it goes 10 or even above. So we like to use that TSH of an indication of 3 or so. But we also want to look downstream. We want to look at T4 free and T4 total. We want to look at how much hormone is the thyroid actually making. Because sometimes we see TSH high, right? And then we see T4 is adequate, meaning, okay, the thyroid is compensating by making enough thyroid hormone, but it's having to whip that horse a lot. Meaning, hey, that horse is going that normal speed, but we're having to whip it a little bit more than we should, meaning we're eventually going to fatigue that horse out over time if we have to maintain that level of whipping. So the goal is, okay, good. So the horse is able to do its thing, but over time, it's not a good thing if we whip it that much. And then we have scenarios where we see T4 starting to drop. And that's a concern because that tells me that, all right, we're overstimulating, we're over whipping, and the thyroid is still not motivated enough, even with that stimulation, to make more thyroid hormone. That's a concern. We also have to look at the conversion downstream because some people we see, okay, that T4, that horse is going a good speed, but the conversion to T3, the active thyroid hormone, doesn't really fit into the horse analogy, but that active T4 is relatively inactive, 300% more inactive than T3. That T3 has to convert. It has to, you go from typically like a T4 free of like, let's say around 1 to 1.5. That has to convert downstream to T3 at about 3 to 3.5. And if it starts dropping below that, where we have a good level of T4 around 1 to 1.5, and that T3 drops into the low 2s, we got a problem because that's our relatively active thyroid hormone being that T3. So we have to make sure it's converting optimally. That's number one. Number two, we have to also address the TSH. We don't want the volume of that TSH to be so high. We want to get that under control as well. And we also want to make sure the T4 is good and the thyroid conversion is good. So we're looking at TSH, we're looking at T4, number 2, we're looking at T4 to T3, number 3, and then number 4, we're looking at thyroid antibodies. Is that TSH being attacked, or is that TSH compensating because that thyroid's being attacked and the hormone is not quite optimum? And then number 5, the 5th variable, is going to be reverse T3. Are we converting some of that T4 to reverse T3? So we have TSH is the first domino. T4 is the second domino. T3 is the third. This is where the T4 to T3 conversion happens. Zinc, selenium, magnesium, healthy CoQ10. Of course, glutathione is going to be involved. Superoxide dismutase, cortisol, and insulin. This conversion happens here. We have the subconversion, which is reverse T3, and this is the blanks in the metabolic gun. So when we see T4 go into reverse T3, that reverse T3 congests and blocks up that thyroid receptor site and prevents active T3 from going in there. This is vitally important if we have thyroid issues. So most conventional medical docs are looking at TSH, that's it. Maybe they look at T4, but they're not really looking at it in depth. They're not running T4 free or total. They're not looking at the conversion downstream. And you very rarely have thyroid antibodies looked at because, well, thyroid autoimmunity doesn't matter. We're not going to do anything from a conventional standpoint. We're not going to give immunosuppressive drugs. We're not going to give corticosteroids typically because the side effects are worse than the actual disease. So they've kind of made, let's just say, an analysis that we're going to save those for more serious autoimmune conditions like Crohn's or ulcerative colitis, those kind of things, because the medications aren't warranted for the symptoms. But the problem is, if we see autoimmunity, which we know about 50 to 90% have an autoimmune mechanism involved, that means a lot to us functional medicine docs. Why? Because we're going to look at leaky gut, aka gastrointestinal permeability. We're going to look at infections. We're going to look at gluten sensitivity. We're going to look at certain nutrient deficiencies that are really important for autoimmunity, such as low zinc, low selenium, low CoQ10, really important nutrients to run our thyroids. And also CoQ10 is going to get blocked if we're taking a statin. So of course, if you're taking any statin medications, you're going to have some problems with your thyroid as well, because you're not going to make your own internal CoQ10. So kind of recapping, right? Conventional analysis. All right, analyze symptoms, palpation. Palpation's only going to be good if there's an extreme autoimmune attack. And then, of course, they're going to assess and maybe run TSH, T4. If you have a better doctor who's assessing the autoimmune stuff, they may run a thyroid ultrasound. Okay, great. So now we get an assessment of inflammation. Typically, not too much will be done with that because the drugs typically are worse than the actual symptoms of the autoimmune thyroid. Next step is, how does that hormone cascade look? TSH, T4 free in total, T3 free in total, reverse T3, thyroid antibodies, and we can even look at T3 uptake as well. We want to look at the whole kit and caboodle. Now, if we want to dive deeper, I refer you to other podcasts where we can look at adrenal health, because cortisol plays a huge impact. We also know as a female, right, estrogen dominance, aka higher estrogen, lower progesterone, relatively speaking, progesterone has a big impact on thyroid function as well. And then we add in the elements of insulin resistance, excess carbohydrate, insulin resistance, or reactive hypoglycemia can exacerbate autoimmunity, affect thyroid conversion as well, and obviously deplete a lot of nutrients just through having to run more glycolysis for our fuel. We tend to burn up a lot more B vitamins and magnesium and really important minerals. And then if we add in the extra vector of hypochlorhydria, low stomach acid from gut infections, then it makes it even more apparent that we don't have enough acidity to ionize our minerals, get them into the blood, and be able to break down, absorb, and digest our fatty acids, cholesterol, and amino acids. So it's quite the cascade. So most people need to get the full thyroid workup. Go to your conventional doc, fine, get at least the big things ruled out. But then once you're told, hey, it's all in your head, you really want to go see, or if they don't give you much of an option, or maybe they just say, here's some Synthroid. The other option with that is, a lot of people, when we talk about that T4 to T3 conversion, my clinical experience is about 80% don't make that conversion optimally because of all the other important nutrients that are involved in that conversion. So that's why you got to look at the full, complete picture. And most people, Synthroid won't get the job done. It may make your TSH look pretty, meaning get it back to about a 1, but it may not help the rest of that hormone cascade because the conversion is not there. It's just T4. And many people don't have all the other nutrients to make that conversion downstream. All right, so I'm live here. I'm going to open it up to some questions in the topic of thyroid health, and anything that we can tangentially connect back to thyroid and thyroid lab testing. So let's go dig in to what the listeners have to say here. What do we got, y'all? Neem writes in, low TSH, insulin, bile, and cholesterol due to chronic infection. Any recommendations? Yeah. So if TSH is low, that means your hypothyroid, that means your pituitary is going basically low, right? You've almost a hypopituitary issue. And if you're not taking too much thyroid hormone, It's probably just because of stress and cortisol and inflammation. So you have to get the diet right, get the adrenals right, and get the gut right. So 6 R's on the gut: remove the bad foods, replace the enzymes and acids, repair the gut lining and the hormones, all of it: thyroid, female hormones, and adrenals, and then eventually deal with body system 2 and getting rid of the gut infections. Hey, I'm Matt. Hope you're enjoying today's show. Super writes in: Hashimoto's, high cortisol, please the vitamin C. So yeah, vitamin C is helpful. I have no problem with that. It's going to help with inflammation. No problem there. Justin G writes in: Hey, Jay, I am 64 male, low to normal T4 and T3, C 6.4 TSH, no swelling, no symptoms other than anxiety, no meds taken, some evidence of autoimmune antibodies. Doc says monitor without meds. So if you're having some thyroid symptoms, personally, with low normal T4 and T3, I'd want to know, is there any antibodies at all? You mentioned some evidence of autoimmune antibodies. So I want to know what those levels look like. And I would definitely add in a little bit of bioidentical thyroid hormone to knock that TSH down. I didn't go into this, but I think it's important. A lot of doctors get freaked out over TSH going too low. I had a patient just before I jumped on today's live podcast whose doctor was concerned about TSH that was too low. And this is the problem. When we're actually using thyroid support, sometimes that TSH can go too low because we're supporting the thyroid, that the brain's saying, hey, we can lower our volume because the thyroid's getting extra support, so let's lower the volume. Now, when that TSH goes so low, let's say below 0.3, a lot of doctors get concerned of Graves' disease. Remember, we talked earlier, Graves is an autoimmune attack where it affects TSI, thyroid-stimulating immunoglobulins, or TSH receptor antibodies, where it stimulates the thyroid to make more thyroid hormone. So when they see TSH low, they're thinking there may be a Graves attack that's hyper-stimulating the thyroid. But really, it's just we're giving a little bit of thyroid hormone, and we're focusing on the thyroid hormone being in the therapeutic range and not necessarily worried about the TSH being in the right range. The problem is TSH, when we give exogenous thyroid support or hormones, the TSH tends to be more receptive to the exogenous hormone than the actual tissue is. So what does that mean? My analogy, my famous analogy is go outside and try to figure out in a hot day what the temperature is by touching the sidewalk. Well, the sidewalk conducts heat more or better than the air temperature does. So 100-degree outside in Austin is going to be like 170 degrees, or like 150-degree sidewalk. So your pituitary is like the sidewalk in this analogy. It's more sensitive and picks it up. So you tend to see a lower TSH when we give thyroid support. And the problem is, if we base everything off of TSH, we tend to be under supporting the thyroid hormone levels, meaning if we're shooting 50% to 25% of the reference range, right? So if we have a range of, let's say, T3, the T3 is like between 3 and 4.5. Let's say we're shooting for 3.5 to 3.75. We may undershoot it if we're trying to just hit the TSH. So essentially, you want to look at the thyroid hormone. You want to look at the TSH too. Ideally, if we can have the TSH not go below 0.3, maybe ideally have it settle around 1, that's great. But sometimes I have patients that their TSH is at 1, but they still have low thyroid symptoms. We go up another grain with their thyroid support, and it's like, boom, the symptoms are gone. So what should we do? Should we make the TSH on the lab look pretty, or should we focus on the patient's clinical outcome, their symptoms, and their actual thyroid hormone levels? Meaning, let's say they're in the top 25% of the range, that's where their symptoms go away, but at the top 25% of the range for T3 free, that may cause their TSH to go a little bit low. But if we go, let's say 50% of the range for T3, their TSH looks perfect, but some symptoms creep up. So you got to weigh out all the options. A lot of doctors, even some natural ones, prioritize TSH over the patient's symptoms and thyroid values. I weigh both of them up. Sometimes we can do both. Sometimes we can't. So we have to look at all of the issues. Are we addressing the adrenal issues? Check. Are we addressing the thyroid issues? Check. Are we addressing any female or male hormone issues? Check. Are we fixing the gut? Check. Are we supporting the nutrients that help the thyroid get better? Are we supporting blood sugar and insulin resistance? We have to look at the whole entire picture. If you just look at the thyroid and your whole treatment plan's off of TSH and these numbers and that's it, maybe missing the forest for the trees, so to speak. So we got to have a complete perspective, and we have to take the TSH and the T4 and the T3 all in context, because most people on the conventional side, they prioritize it to TSH, partly because that is the main thing they're looking at to analyze Graves. And I think because conventional medical doctors are overly concerned about Graves because it can mean stroke or heart attack. So they are, our thyroid storm essentially. So they are hyper focused on the TSH, where in functional medicine land, we look at the full thyroid hormones typically. So if there is Graves, we're going to see it down the road with T3 being excessively high and or T4 being excessively high. And then we'll rule it out by ordering additional thyroid stimulating immunoglobulin and TSH receptor antibodies as well. We won't just ever take it for granted. Okay, let me keep on rolling, guys. I went into a pretty in-depth on that one, but hopefully it was helpful. T4 to T3 conversion issues. Yeah, that's going to be nutrients. The 5-deiodinase enzyme is going to be an important enzyme. It's selenium-based. It comes from the liver. So liver stress, liver issues, toxic liver, low selenium, low glutathione, magnesium, zinc, important digestive nutrients and minerals, vitamin A, cortisol high or low, insulin too high or too low. This is partly why lower carb can sometimes cause low thyroid symptoms. We add a little bit of starch in, boom, low thyroid goes away. Or the other way around, we see high blood sugar, we get the blood sugar under control, we go on a keto paleo template, and then boom, magically insulin gets better and thyroid gets better too. So we got to look at everything is connected, all right? Ahmet writes in, reactive hypoglycemia, autoimmune relation. Yeah, so when you have reactive hypoglycemic blood sugar swings, this is when you may consume too much carbohydrate, all right, not enough proteins or fat, or you're just going too long between meals and then you're eating a bunch of carbs, blood sugar goes up, and then your body over-secretes insulin and it crashes. And the crash is the reactive part, meaning you're reacting into low blood sugar because the pancreas made extra insulin, and that drop creates lots of cortisol and lots of adrenaline to bring that blood sugar back up. So what you're seeing is lots of cortisol and blood sugar, cortisol and adrenaline surges to bring back up that blood sugar, if you will. Would very high TSH and normal T3 and T4 in postmenopausal women mean adrenal issues due to estrogen dominance? Would very high TSH, normal T3 and T4, potentially. I mean, it's one thing that would be on our checklist that we'd want to cross off and make sure it's not a vector. So yeah, it's potential, but it could be autoimmune. It could be other things with the adrenals too. Best Graves treatment. So, I mean, we treat Graves the same way as we treat Hashimoto's in general. Of course, if thyroid hormone's really high, we may recommend PTU or methimazole, which is their conventional drugs to actually block iodine uptake. Or we may use more natural things like carnitine or lithium orotate, or blue flag, various herbal compounds. Again, it just depends on how severe, how bad the symptoms are, and we want to look at the numbers and make sure they're not too high. I typically refer out to an MD just to get stabilized while we work on all the other underlying things. Gluten as well is a big one. But you want to have a good conventional MD as well as a functional MD. The problem is a lot of conventional MDs can freak out, and sometimes I had some patients get recommended to get their thyroid removed right away, which is a terrible move, right? You gotta understand what's going on here and try to give the body a chance to get back into balance, as long as the levels, let's just say, aren't excessive and we're having cardiovascular issues. Worst case, we use a medication to stabilize while we go deeper. Sherry wrote in, do I still have Graves' disease if my thyroid has been completely removed? It's been 2 years and my levels are all over the place. So number one, you never actually get your thyroid all the way removed. Getting your thyroid removed is like ripping off gum on your shoe. It's probably always going to be some, and some of it can grow back. Not all the way, but you may have some grow back. And then number two, the underlying autoimmune stress is still there. So you have to get the autoimmune mechanism, whether it's leaky gut or other nutrient issues or gut permeability or infections or foods. You have to still get the underlying mechanism removed, right? Why does Graves or Hashimoto's or an autoimmune thyroid happen? Well, it happens because the conditions are just right. If I remove my thyroid, does that change the conditions being just right? No, it doesn't. Lisa writes in, what are the appropriate levels for reverse T3? Ideally between 10 and 20, 12 and 20-ish. Yoli writes in, Dr. J, my lymph node on my neck is swollen and is uncomfortable and painful. What can I do, if anything, to help? And can I continue doing my sinus rinse? Yeah, continue doing your sinus rinse. Obviously, there's swollen lymph nodes in this area. So there's obviously bacteria or your lymph system and your macrophages are trying to gobble up stress in the throat area. So add in ginger, add natural things that are going to help with flushing out the lymph. You can do lymphatic massage right here by the back, the angle of your jaw. And you could just do kind of clockwise turning and massaging like this, and then you can just drain one side right into the thoracic cavity and just drain it all down. That's helpful. You can also add in some burdock tea, which is great for the lymph, and or ginger tea, and you could even throw in some red root or red clover is great for the lymph. But something's going on with your immune system. It's attacking stuff, and it could just be bacteria and junk that's making you sick. So continue with the sinus rinse, because any mucus here can go down the eustachian tube and then go to your ear and create an earache. So you want to keep your sinuses flushed out with Xlear or Neomed. That's fine. And also make sure you're doing the ginger and or some immune support, or you can even do some reishi mushroom to make sure you are fully supported. Emma writes in, Graves, pins and needles on my feet and extreme discomfort, hair loss, eyebrows, on Neurontin, not as effective anymore. So yeah, you got to go see a conventional MD. More than likely, Emma, all the issues that we talked about in today's podcast are happening to you, and you need to get a full workout to see which ones are the top priorities. Roshan writes in, outside of Hashimoto's, what are the hardest to cure thyroid issues? Are most thyroid issues completely curable? I mean, it just depends. The more severe the autoimmune attack is, obviously the harder, especially if it's because of infections and leaky gut, and there's a lot of other autoimmune conditions. Like let's say you have Hashimoto's, but you also have rheumatoid arthritis or Crohn's, right? It's something called PGAS, polyglandular autoimmune syndrome. If you have one autoimmune condition, there's a 76% chance that you have a second autoimmune condition. And if you're a female, it's even higher. Females have issues because of the fact that they have more estrogen than guys, right? Part of the reason why they're fertile, and they're women in general, that higher amounts of estrogen can throw off the CD8, CD4 cell balance and make them more prone to autoimmunity. So that estrogen can really have an effect. And the more the estrogen dominance goes into effect, the higher risk of autoimmunity, because that CD8, CD4 ratio, CD8 being the natural killer cells, the CD4 being the natural or the helper cells. When that balance goes out of whack, increased autoimmunity. That's why estrogen dominance is such a big deal and needs to be addressed. And again, that also includes environmental estrogens, right? Pesticides, Roundup, herbicides, rodenticides, fluoride in the water, and junk in the water, birth control pills in the water, hormones in the meat, all of that stuff, hormones in the milk, all of it. Rhonda writes in, is it bad to have any TPO antibodies? My levels are 9. No, that's okay. It's natural to have some antibodies because there's a natural recycling process that happens. We just don't want it to be excessive. So like LabCorp uses a range of, I think 34 or higher is positive. I think Quest uses 9. So I typically say keep it below 15-ish, and that's pretty good. Roshan writes in, how do fungal or bacterial infections drive hypothyroid? Well, I mean, bacterial and fungal issues can increase leaky gut. Of course, bacteria contains lipopolysaccharides. Fungus contains acetaldehyde and mycotoxins that put stress on the liver, more leaky gut. And of course, they can eat and cause malabsorption of nutrients as well. Paul writes in, could Hashimoto's cause Crohn's or other way around? Well, no. Basically, Hashimoto's and Crohn's are the effect. None of that's the cause, right? These are the effect. Crohn's, Hashimoto's, rheumatoid arthritis. The underlying cause can be a combination of genetic predisposition, which is then triggered by gluten sensitivity, by cortisol fluctuations, by insulin resistance, by inflammation in your diet, by high amount of omega-6 to omega-3, nutritional deficiencies, gut infections, poor sleep, right? So, of course, genetic predisposition is what loads the gun. What pulls the trigger is going to be the stressors that I just mentioned. And then the effects are Hashimoto's, Crohn's, RA. Now, the difference is you may just have that gun ready to go and that hammer already back, right? So you're more predisposed. Where others, let's say, they need to actually put the bullet in, cock the hammer back, and pull the trigger. I mean, they need a lot more things going on for a lot longer for that effect to happen. But either way, we have control if we pull the trigger or not. Whether your gun's already loaded, we still have control over you pulling the trigger. Yoli, you are totally welcome there. Paul writes in, how does low thyroid give cool hands and cool feet? Well, because thyroid hormone controls metabolism, and that's basically the sum of all chemical reactions in the body. So, of course, the more chemical reactions you have, which is controlled by your thyroid hormone, which increases metabolism, the byproduct of your having a healthy metabolism is heat. It's kind of like, do you get enough heat to keep you warm from a small fire or a large fire? Well, a large fire. Why? Because there's more reaction with the oxygen and the fire in the wood, right? And that gives off heat as the byproduct, of course. So, of course, you need more fuel. You need more metabolic reaction happening. More metabolic reaction with the air and the combustion of the wood gives you more heat. It's the same thing with what's happening in your body. And then, of course, we need thyroid hormone to be able to break down cholesterol and break down our hormone metabolites and hormone building blocks so we can make more female or male or adrenal hormones too. So when you have low thyroid, it can affect a lot of your other hormonal systems as well. Rhonda writes in, are all thyroid hormone tests reliable? ZRT, Everlywell? Well, great question. I mean, when it comes to some of the ones like ZRT, or they have some good spot tests. And I've used ZRT. I use their spot test only if someone does not have a conventional lab to get an actual draw on. My concern is I used to run some of the Theranos tests like a couple of years ago before they went out of business. And I found I would compare them to like LabCorp or Quest, and they were very inaccurate. So the spot technology, meaning like it's a little finger spot, it's getting better, but it may still be off a little bit. So I only use ZRT or the spot ones if someone does not have a lab test within 3 hours. If not, we run a Quest or a LabCorp, which is pretty standardized. You need more blood to run those, so it's hard to do it with a spot, meaning just a little finger prick one like you would on a blood sugar meter. But the technology is getting better. But if I can run a Quest or LabCorp where an actual vial or two is run, that is always better. Let me jump on to Facebook here and give you some Facebook love. Sorry, you guys, I have not given you the attention here. All right, Annie writes in, so a whole bunch of, let's see here. I was 17 years old. Ever since recent illness resulting in gallbladder removal, my body's been out of whack. Gut issues, anxiety, never had that before. Yeah, I mean, here's the deal. If you don't have a gallbladder, it probably means you have hypochlorhydria. It definitely means you don't have enough bile salts to break down fat. You're going to have a hard time probably breaking down protein and fat because of the low stomach acid and the low bile. And that puts you in a position to have a lot of nutrient issues. So you really have to work with a good functional medicine doc to get the diet better, to get the digestion better, and to get your hormones better. A lot of issues going on there. And Laura writes in, yeah, gluten is huge. I totally agree. It's a big issue. It's one of the major drivers of leaky gut. See here, without giving Synthroid, can we cure better hypothyroid situations? Well, I mean, yeah, if there's an autoimmune attack, as long as we're getting the autoimmune attack under control, Synthroid will help bring that TSH down, which helps prevent whipping of that thyroid, right? Remember, TSH, the whipping of TSH is not the same as an autoimmune thyroid attack. Not the same, but still, it's still stimulating the thyroid. So by giving a little bit more hormone, that does bring that TSH down, which is good. Lots of people were concerned about, excessive bone loss or thyroid nodules with TSH going too low. But again, from my situation here, as long as it's not excessively too low from Graves', you're more than likely okay. Just make sure your doctor's monitoring your thyroid levels. Megan writes in, can excessive sweating in the warm weather be your thyroid? Hard to say. I mean, it's pretty normal to sweat in the warm weather. I would just run a basal body temperature test and make sure you're utilizing your regular indoor room temperature. That way you're not using any extreme high or low to assess your metabolism. So we want to be between 97.8 and 98.2 for an axillary temp, armpit, and 98.2 to 98.6 for your oral temp. Do it first thing in the morning before you move around and eat. Paul writes in, when's the last time your Hashimoto's gave you an issue, Dr. J? I've been able to keep it under control. I mean, my levels, my TSH stays beneath 2, my T3 stays above 3, my T4 stays between 1 and 1.5, my antibodies stay right on the border. I'm able to keep it in control. Donna writes in, is intermittent fasting okay with Hashimoto's? Only if it's in control. Only if it's stabilized and in control. If it's not, do not do it. Make sure you have your hormones stable first. What nutrients support the pancreas? Well, I mean, of course, we would give enzymes. We'd give more enzymes to prevent the pancreas to have to make extra enzymes. We'd give a stomach acid to help. Those are going to be the big things is, the exocrine function of the pancreas, which are going to be enzymes in lipase, enzymes, pancreatic, proteolytic, or so essentially they're pancreatic enzymes, and they have proteolytic function, meaning protein, and then lipolytic functions, meaning fat digestion. So we'd give a lot of those things to take stress off the pancreas, and we give more acidity as well to the stomach, which is an important trigger of pancreatic enzyme secretion. Ahmet writes in, hypothyroid situation, some doctors recommend low-fat, low-calorie diet. Is it true? I mean, would some doctors recommend it? Yeah, it's terrible. Go into PubMed, type in hypocaloric diet and hypothyroidism. Low calorie causes low thyroid. It makes sense because if the sum of all your chemical reactions, essentially your metabolism, right, is controlled by your thyroid, and you stop giving fuel into your thyroid, or meaning you start giving low calorie, aka low nutrition, low fuel, you are not going to have enough nutrients to run your thyroid, and that's going to cause low thyroid hormone functioning. Same thing, if I put less gasoline in the tank of your car, eventually you run empty. It's the exact same thing. Ron writes in, if my basal temperature is in the lower 97 degrees, is that a thyroid problem? Maybe, maybe not. It really depends on your symptoms, and it depends on what your thyroid test says as well. I don't ever go all in on the basal temp, because that can be other issues, and sometimes it can just be a broken thermometer too. So we want to look at your symptoms, and we want to look at your hormone levels. All right, jumping over to Facebook. Hypothyroidism and I'm hypothyroid and diabetic, have beginning of gastroparesis, am concerned of the meds prescribed. Armor may not be metabolized if it sits in the stomach too long. So yeah, so if we have digestive issues, Kathy, I definitely recommend absorbing your thyroid hormone in your mouth sublingually to bypass a lot of that, then swallow after 1 to 2 minutes. But you want to work with a good functional medicine doc as well. Reggie writes in, been suffering from autoimmune thyroid condition for the past few years. My throat was enlarged, but after taking some herbs mixed with garlic, padiarco, oregano, leaf zinc, and vitamin C, it has gone back down. Yeah, a lot of those herbs are also antimicrobial, so I wouldn't be surprised if there's some gut issues, bacteria, yeast, or fungal that could be part of what's stressing out the body. It's very possible. All right, guys, I think we answered a lot of good questions here. Just make sure you sign up for the Thyroid Reset Summit. We're going to go into all these things. I have 30 experts that I've already interviewed, amazing interviews where we go into depth in all these different topics. So totally free to sign up, thyroidresetsummit.com. You'll be able to see my own personal interview, Evan's interview, and a bunch of other amazing experts interview. You guys are going to love it, and it helps support the channel and helps support more content coming to you. So appreciate you guys signing up. And I will be back tomorrow for a live Q&A. I'm trying to get better at giving you guys a heads up. So sometimes I'm like, oh, a patient is missed their consult. I jump in, or it's the end of the day and I put my son down for bed. I have a half hour free. Let me jump on. So I'm going to try to get better at giving you guys maybe 24-hour heads up. Let me know how much time you want. Put your questions down below. I'll answer it later. And let me know future topics, future live podcast topics you guys would love to hear about. I love being on the fly and dynamic, so we can make this show interactive and get your questions answered. So I appreciate it. You guys have a phenomenal day, and I will be back tomorrow. Take care.